All right, everyone. So now we're going to get started with Module 6, Adult Respiratory. And so, I believe in you guys, and I love to start off with a word of prayer. Our dear Heavenly Father, Lord, thank you so much for today. Thank you for waking us up. Every day of life is a precious gift. Lord, as we're going to learn about the lungs today, thank you, Lord, that we can all take a deep breath by ourselves. We're not in the hospital connected to machines to breathe for us. We don't need an inhaler, Lord. Thank you so much. And I pray that every breath we take, we give you praise. And I pray that everything in our lives, in our children's lives, in our families' lives would give you glory, would bring you glory, God. And I pray that each and every one of my students will pass the NCLEX and become successful, excellent nurses. In Jesus' name, amen. All right, guys. So basic anatomy. So the respiratory system, you have the nasal passages, you have the oral passages, you have your pharynx, you have the trachea, you have the bronchi. So here's your trachea, right? Your trachea, and then you have bronchi. You have two bronchi, and then the bronchi break up into bronchioles, and then the bronchioles will end at the alveoli. Okay, and so it's very important to know that the alveoli is where gas exchange occurs. Okay, so it is very important to understand the process of ventilation and understanding that we breathe in oxygen and oxygen goes into the alveoli. And when blood flows through these capillaries here, oxygen is going to diffuse. Okay, and it's going to go through the alveoli and enter the bloodstream. And that oxygenated blood is going to go back to the heart to then go to the left atrium, the left ventricle, the aorta, and then to the rest of the body. Type yes if that makes sense. Very good. Okay, so the whole reason why we inhale so that our body can receive oxygen into our airways, and then that oxygen can enter into our bloodstream. And where does that happen? That happens at the site of gas exchange. And where is the site of gas exchange? The alveoli. Now, there's a step that happens before the blood receives the oxygen. Before the blood receives the oxygen, this deoxygenated blood here, this deoxygenated blood is oxygen poor, and it's going to give CO2 away. Okay, so CO2 is going to leave and enter the alveoli. And at that same time that CO2 leaves the oxygen poor blood, the oxygen poor blood will receive the oxygen from the alveoli and now become oxygen rich. I want you to type yes if that makes sense to you. That's what gas exchange is. Gas exchange is the deoxygenated blood gives away CO2 so that it can now pick up oxygen and go back to the heart and back to the left side of the heart and through the aorta to perfuse the body. That is what we call gas exchange. Okay? And here, let me pull up another picture for you that can make it a little easier. Because I'm a picture person. So this is another picture that can show you. So here's oxygen poor blood. So this would look like a small venule, like the blue small vein. So this is oxygen poor. CO2 or carbon dioxide is going to diffuse and pass through from the blood vessel into the alveoli. And so it's depositing CO2 so that it can now pick up oxygen and then it's going to leave. Okay? And CO2 is going to leave the body when we exhale. Oxygen enters when we inhale. One of the most important things, okay, so type yes. If you're with me, you got it, you understand. One of the most important things you have to understand here. Okay, so somebody said no. Tell me what about it you don't get? Because understanding this is going to make understanding the disease is a lot easier. What don't you understand? I'm here for you. Okay, take your time and type it in the chat so I can help you. But one of the most important things to understand is that the alveoli must be clear. It doesn't, you can't have water in here or fluid or pus. Because do you think if there was fluid in here, do you believe that this would impair fluid exchange? A gas exchange, excuse me. Do you think that this would affect gas exchange if there was fluid inside the alveoli? Absolutely, absolutely. So we're going to see as we start learning about certain diseases that it's so important that the alveoli remain open. We don't want them to be smushed or flattened. And also the only thing that should be in alveoli is air. And when I mean air, I'm talking about the gases of air, oxygen and carbon dioxide. Okay, very good. Um, Miss Daphne's asking, are we using the book or no? No, this is just like foundational, like kind of like an anatomy and physiology review. I've learned that it just makes it easier before we get into the diseases to review the anatomy and physiology. Okay, all right. Next up, we're going to talk about lung sounds because didn't I say it's really important that the only thing that's inside your airways be air, right? Airway, the only thing that should be inside your airways should be air. And when we say air, we mean the two gases, oxygen and carbon dioxide. So one of the ways that we assess how a patient is doing is we listen to their lung sounds, okay? So, some important things for you to know is do not auscultate over a bone because you won't hear anything. You auscultate over soft tissue and you want to listen to both the front and the back and you want to listen to both sides and you do it in a staircase fashion. The way that you do it is you start on one side and then you immediately listen to the other side so that you can compare, right? And this would be the patient's right. Because whatever you're facing the patient, it's the opposite. So you listen to the right side, then compare it to the left. Then you go down and you listen, then you compare it. Then you go down and you listen, and then you compare it. Then you go down and listen, and then you compare it. So now these are the vowel sounds, right? But this is just showing you how to auscultate in a staircase fashion. So I listen to lung sounds first, front and back, okay? And you do the same staircase fashion on the back, okay? You always want clear lung sounds. So let's talk about that. So, some important words that you need to know for NCLEX, vesicular or bronchovesicular. They mean the same thing. Vesicular or bronchovesicular lung sounds are good lung sounds. They're normal. They indicate that it's only air in the lungs. Okay, so if you see that on NCLEX, vesicular lung sounds, bronchovesicular, everything is fine in terms of lung sounds. Okay, that is in your study guide. All right. Next up, I want you to know adventitious. Adventitious lung sounds are bad lung sounds. They are abnormal, okay? So just think of it like if you see adventitious, like, oh, those aren't good. They try to take advantage of you. Those are not good lung sounds. So vesicular, bronchovesicular, good, normal. Adventitious, abnormal. All right, so let's listen to what normal lung sounds sound like. You see how that just sounds like air? All right, everyone. So just put it in the chat. Were you able to hear that? Did you hear the lung sounds? That was normal lung sounds. Okay. So it sounded like just air, right? Just air moving in and then moving back out. Moving in and moving back out. So that's what you want your lung sounds to sound like, okay? So now let's talk about adventitious lung sounds. So first up is crackles. The old name for crackles used to be rails, and it's okay because how are you going to remember? And let me just silence my phone. Hold on one second. It's driving me crazy. Hold on. Okay. So we have RALES. So the name rails is inside crackles. So you don't have to panic. If you ever see rails, it means the same thing as crackles. I believe rails are a little bit more severe sounding or indicate like more fluid. However, crackles. What does it indicate? Crackles indicate that there are fluid in the lungs. So the sounds that you might hear when you're auscultating crackles, popping, wrinkling paper, or it sounds like you're opening a bag of chips. Some people say a snap, crackle, pop. And when are you more likely to hear crackles when you're listening to lung sounds is if the patient has congestive heart failure or any condition that causes fluid overload. So some common interventions that you might encounter on the NCLEX when we're talking about crackles include maybe the patient was getting IV fluids and all of a sudden they begin to develop shortness of breath and crackles. You would want to stop the IV fluids and give diuretics. So now let's listen to crackles. Oh, hold on, I cut the video off. Hold on, I'm sorry. All right. So what was the difference? What was the difference when we first heard vesicular lung sounds compared to the crackles? Someone tell me in the chat. With the first lung sounds we heard for vesicular, it sounded just like air, but this video that we just listened to for crackles, didn't you hear kind of like a popping or crunchy? It sounded crunchy, right? Exactly. So yeah, some people say it sounds like you're crinkling wrapping paper. And in nursing, we call that the wet. We call it that the lung sound wet. Or some people say junky. The lung sounds really junky because that's fluid. Let's listen to it again. All right. Next up is rhonchi. So we know we're all comfortable that crackles indicate fluid, right? Crackles indicate fluid. And just remembering that when we're talking about crackles, it's usually a patient with heart failure or fluid overload. And we're going to consider, and we'll learn, but like diuretics, suctioning, things of that nature. But now we're talking about another type of adventitious lung sounds, which are called rhonchi. Okay, so hang on a second. I did not mean to do that. Okay, So you can think of the R in rhonchi as rumbling. Okay. And then hang on a second. Or you could think of like lim. If you speak Creole, lim, mucus. Okay, because that's what it is. Rhonchi, it's the sound that happens because there's too much mucus in the airways. So crackles is too much fluid. Rhonchi is too much mucus. So what does it indicate? Rhonchi indicate too much secretions, and it sounds like a rumbling or snoring. So when are you going to hear rhonchi, COPD, bronchitis, cystic fibrosis? So interventions to help patients with rhonchi, deep breathing and coughing will help to loosen secretions, and hydration will help to loosen secretions as well. Because, and make sure you write this down, thicker secretions are more difficult to get out of the body, right? Because they kind of stay stuck to the airways. But the more hydrated the patient is, the thinner the secretions become, and the easy they are to cough out. So when you think about your patient with pneumonia who's too sick and hasn't been drinking all day and they're very dehydrated, what happens is the secretions become thicker and more difficult to cough out. So let's listen to Ronkai. What does it sound like to you? Snoring. To me, it sounds scary. See, it can be cleared by coughing. Okay. So, what have we learned so far? Crackles are because of fluid, and crackles are more associated with like CHF and fluid overload, right? The nurse mainly said when you're driving and your windows are open. Yeah, right? So crackles are associated with fluid, CHF, fluid overload. And for crackles, we could, stop IV fluids if it was causing fluid overload, diuretics, suctioning, rhonchi, think rumbling, think limb, right? And that is because of too much mucus. So that's associated with like COPD, bronchitis, cystic fibrosis, pneumonia. And so, what would help the patient is coughing. Coughing is going to help clear the mucus out of those airways. But remember, thicker mucus is more difficult to cough up. So, what do we want to encourage in the patient to make the secretions easier to cough up? Very good. Hydration. Hydration is going to loosen the secretions and make them easier to cough up. So, what position do you want your patient in when they have rhonchi? Do you want them laying flat? No, right? Do we want them semi-foulers or high foulers? Up. Very good. So it can be semi-foulers, it can be high foulers, especially high foulers if their O2 saturation is low. But the more upright the patient is, the more ideal for their condition, because the more upright we are, the more we're promoting proper ventilation, right? The more we're allowing the lungs to properly expand without the weight of the chest and the heart pushing down on the lungs. Okay, so we want the patient as upright as possible, especially if we're going to promote hydration. So if we're going to promote hydration like drinking water, we already want them sitting up. But even if that hydration is through IV, we want them sitting up so that when they do cough, that they're already sitting up. We don't want them laying flat and choking on their secretions. Okay. Now, when a patient needs to be coughing to clear their airways, is the patient going to always do it on their own, or sometimes are we going to have to educate the patient and help them to do it? Yes, we're going to have to show the patient how to cough and deep breathe. We're going to show the patient how to properly remove the secretions, and we're going to have to sometimes watch them do it to make sure that they're doing it correctly. All right, next up is wheezing. What it indicates, make sure you understand that, and this is all in your study guide, correct? This is all in your study guide. Excuse me, everyone, give me a brief moment. Thank you. Yes. All right, so make sure you know that wheezing is a sign of respiratory distress. So if you ever see wheezing on the NCLEX, this is an emergency. It is not normal for someone to have wheezing because it indicates an obstruction of the lower airway and air cannot get through properly. And what is even more dangerous than wheezing is if the patient was wheezing and then all of a sudden there's no breath sounds. What do you think that indicates if the patient was wheezing, but then all of a sudden we lose the breath sounds completely? What do you believe has happened to that patient's airway? Very good. So exactly. So if somebody was wheezing and then all of a sudden we stop hearing and we don't have any lung sounds at all, we have complete occlusion, complete obstruction of the lower airways. And you wouldn't even really need to like try to figure that out. You would see that the patient has stopped breathing altogether, and then they're just having agonal respirations. So let's listen to something. But first, let's talk about the sounds. The sounds of wheezing is a high-pitched musical okay, it's like blowing through a flute. So when are we going to hear this asthma attack or the most severe type of allergic reaction, which is called anaphylaxis? So make sure you know that for NCLEX. There's two times that you're going to hear wheezing. Yes, there's other times, I'm sure. But what I want you to know for NCLEX is you're going to hear wheezing for asthma attack and anaphylaxis. Okay? You could even hear wheezing with somebody with CHF, like with really bad fluid overload. Interventions, we're going to learn the interventions when we get to each specific disorder, okay? So let's listen to wheezing. Okay, so you hear it has a very musical characteristic to it. So let's look at a picture. And I want to see who's paying attention. We said that wheezing is an inflammation or obstruction. Is it of the upper airways or the lower airways? Of the lower. Very good. So keep that in mind. Wheezing is lower airway obstruction, right? So now let's look at this picture together. Let me see if I can make it a little bigger. So, first of all, this is a picture of an asthma attack. So here we have normal airways. And when we say airway, we're talking everything from the nose, the mouth, all the way down to the alveoli. So the nose, the mouth, the pharynx, the larynx, the trachea, the bronchi, the bronchioles, the alveoli. Those are all your airways, right? Okay. So here we have a normal airway. This is the way that air gets to the alveoli, right? And then now let's look at an asthmatic airway, okay? So first off, let's look at these. These look like rubber bands that are wrapped around the bronchioles. So your bronchioles are wrapped in smooth muscle, okay? So in the normal airway, the smooth muscle is relaxed. But here in a patient with asthma, having an asthma attack, it looks like the smooth muscle is like choking the bronchiole. This is what we call bronchospasm or bronchoconstriction. This smooth muscle is tightening around the bronchioles and it's closing off the airway. So that is one way where we have reduced gas exchange or an obstruction of the airways. So this is going to reduce how much oxygen can get in and it's going to decrease how much CO2 can get out. Does that make sense? So that's the first way that an asthma attack can lead to obstruction of the lower airways. Then we have a thick mucus plug. That's definitely going to impair gas exchange, right? And that's definitely going to serve as an obstruction of the lower airway. Okay, then we have a swelling or inflammation of the airway lining. So we can see the airway lining here is pretty thin, but here we have that it's inflamed. So that's going to reduce the lumen size of the airway here. So we have these mechanisms that are causing lower airway obstruction. We have bronchospasm and bronchoconstriction where the smooth muscle is choking the bronchiole. We have the mucus that's blocking the airway, and we have inflammation that's reducing the size of the airway. We can see it's very constricted here. So as air fights to get through these tiny airways, that's where we get the wheezing. And how does your patient look? Does your patient look like she's doing all right? Does your patient's not having the best Monday morning? Okay, she's having an asthma attack. And we have to give her a rescue inhaler of albuterol. Albuterol is a bronchodilator, and it's going to cause this smooth muscle to relax, and it's going to cause the bronchioles to dilate, bronchodilator. It's going to cause dilation of the bronchioles and open up the airways, and then she's going to cough this mucus out, okay? So I want you to know wheezing is a sign of respiratory distress. The two times I want you to know that you're likely to hear wheezing is asthma attack and anaphylaxis, okay? And I want you to know that wheezing is caused by lower airway obstruction. Next up is stridor. Stridor is another indication of respiratory distress. So stridor is an emergency and it indicates obstruction or inflammation of the upper airways and causes air to not get through properly. So wheezing is lower airway, stridor is upper. okay? And you could think of it like an ABC order. S comes before W, so S, stridor is upper airway obstruction, wheezing is lower airway obstruction. Here's a picture. It's a little blurry, but it's blurry. But so stridor would indicate upper airway obstruction. So this is more like epiglottitis issues, and then wheezing would be down here in the lower airways. Does that make sense to everyone? All right. So the sounds, stridor, it's still a high-pitched musical sound, but guess what? Um, you don't even really need a stethoscope to hear stridor because it's in the upper airway. And sometimes you don't need a stethoscope to hear wheezing either. But these are both emergencies. So when are we going to hear stridor? The two times I want you to know for NCLEX are croup and epiglottitis. So wheezing is asthma attack and anaphylaxis. Stridor is croup and epiglottitis. Wheezing is asthma and anaphylaxis. Stridor is croup and epiglottitis. So let's listen to stridor. All right, so those were the major lung sounds that you have to know for NCLEX. So remember, crackles are associated with fluid, and we're going to hear crackles with CHF and fluid overload. And for crackles, if it's because of fluid overload, diuretics can help the patient. Maybe even suctioning could help as well. Then we have rhonchi. Rhonchi is like the rumbling because of mucus. And we're going to hear rhonchi with COPD. We're going to hear it with cystic fibrosis, pneumonia, and coughing and deep breathing, hydration to loosen the secretions, and suctioning can help the patient as well. Then we talked about wheezing. Wheezing is that high-pitched musical sound. It's an emergency. It indicates lower airway obstruction, and it's associated with asthma and anaphylaxis. Then we learned about stridor. Stridor is also high-pitched and musical, but it indicates upper airway obstruction. Okay, and we're associating that with croup and epiglottitis. And when we get to peds, we will learn how you treat both. Okay. So next up are some important words to know for breathing. So you have to know all of these words, and they are in your study guide. I saw someone said that they're having trouble access the study guide. So before you get to break, I will show you all how to access the study guide again, okay? So breathing. So apnea, the patient's not breathing at all. Bradypnea is less than 12 breaths a minute. You can also say hypoventilation and respiratory depression. Tachypnea is more than 20 breaths a minute, hyperventilation. Dyspnea is shortness of breath or difficulty breathing. Dyspnea on exertion is when the patient gets short of breath when they perform an activity. Orthopnea is difficulty breathing when they lay flat, and they're usually going to have a pillow count, which is I can only go to sleep at night if I have two or three or four pillows. And that's common with CHF patients. And then we have Kussmaul's breathings, which is deep and rapid. Okay, apnea, bradypnea, tachypnea, dyspnea on exertion, orthopnea, and Kussmaul's. You don't have to write this down. This is all in the study guide. All right, guys. So before we take a break and we move on to procedures for the respiratory system, everyone go to the last text message I sent you or the last WhatsApp message I sent with the recording where it says, "Good evening, everyone. Here is the recording from today's lecture, Adult Cardio Part 6." And click on that link. And at the top of the link, you should see study guide. And when you click on that link, the study guide should always open. So every week I'm sending you the same link. I'm just adding the recording on. So you should still be able to open the study guide. It's the first link on that page. Okay. So if you're having trouble accessing the study guide from that link, let me know. And just type it in the chat if you're having issues. Okay, so go to the WhatsApp, go to the last link I sent you where I said, mhm. So let me send the link again on WhatsApp. So I just sent a new message just now. So open WhatsApp and open the NCLEX group chat, and you should see the class link and click on it. Okay. All right, guys. So let's go ahead and take a 5-minute break. We'll come back at 11:05 and then we're going to learn about important procedures for the respiratory system. Okay, such as a laryngoscopy, bronchoscopy, and thoracentesis. Thank you. There were two other words to describe breathing that I just wanted to make sure you know. It is in the study guide. Cheyne-Stokes and O breathing. So both of these, you're going to see this like in hospice patients who are near death. So Cheyne-Stokes is a pattern. So think chain as in Chain, chain. Cheyne-Stokes is like a pattern of the breathing gets deeper and deeper and then it stops and then it gets deep and then they start breathing again deeper and deeper and deeper and then it stops. And it's a pattern like that, and you're going to see that like in hospice patients. And then O breathing is when they make a O with their mouth, and you also see that in hospice patients. So that is in the study guide. So I just want to make sure that everyone knows it's very important to read the study guide, because when we come together for class, we're talking about the most important topics. We're talking about the content that you're most likely to see on the NCLEX, but for you to get like a very well-rounded picture on the topic, you have to read the study guide. So make sure if you have not read Module 6 in the study guide, you open up that study guide. I just sent everyone the link, and you click on study guide, which is right at the top, and go to Module 6. Module 6 starts at about page 190, okay? And you'll see it says Adult Med-Surg Respiratory, okay? And here I'll show you what it looks like. So you'll see. Okay, okay. So I know it says 184 here, but on the pages of the document it's 186, but it's fine. Just find module 6 and then respiratory starts like page 188, but it says 190 here. And just read through it. And so as you can see, everything that we've went through so far is there, but it's just very important that you know that. Also, making sure you know that at the beginning of each chapter, you're going to see these check boxes. These are the things you absolutely have to understand about that system for you to pass the NCLEX. So that also will save you time and help you to focus properly when you're studying. All right, so some diagnostic exams you have to know. So let's talk about what on earth is the larynx. I could never, when I was in nursing school, I never understood what was the difference between the pharynx and the larynx. Okay, so the pharynx, I want you to think P is for passageway. So hang on. Okay, and you have technically two divisions of the pharynx. You have the nasopharynx, and then you have the oral pharynx. Okay, so let me get some arrows. Okay, so the space behind the nasal cavity, as you can see here, and let me get a circle, hold on. Right? So this is the nasal pharynx. This, the space behind the mouth, is the oral pharynx. So usually when you're like, oh my gosh, I have a sore throat, that's called pharyngitis because your oral pharynx is inflamed. So the pharynx is just a passage. It's just a way for air or mucus in the oral pharynx, food, liquid. It's just a passageway for substances to pass through. Then we have your larynx, okay? Your larynx is your voice box, okay? So I always think larynx, la, 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 okay? So your voice box, that's where you talk from, that's where you sing from, that's where you have your vocal cords, okay? And your larynx is what they look for, and we're going to see it in a little bit. Your larynx is what they look for when they're intubating a patient. Because here's this tricky part about this whole setup here in your neck. Okay, so remember, your trachea is in front and your esophagus is in the back. So when we're intubating patients, one of the trickiest parts of intubation, especially in an emergency, is making sure that we didn't put the tube in the esophagus, because then all we're going to do is puff up the stomach and make the patient throw up, and they're not getting any oxygen. So one of the landmarks, the anatomical landmarks that they're going to look for when they're intubating a patient is they're going to look for the vocal cords, which is the larynx. And once they see the vocal cords and go through the vocal cords, they know that they have intubated the trachea. Okay? So some important things to differentiate. Pharynx, the P is for passageway. You have your nasopharynx and you have your oral pharynx. So, for example, somebody has a sore throat. They usually call that pharyngitis, right? Then you have your larynx, which is your voice box, and that's where your vocal cords are. And the V in vocal cords is so funny because the vocal cords make a V. I'll show you a picture, okay? Your larynx, your voice box, that's how you're able to speak and whistle and sing and yell because of your larynx. And so let's say somebody has a very bad infection and they lost their voice and they can't talk. I lost my voice. That's called laryngitis, right? So you've got pharyngitis, you've got laryngitis. And I also want you to know the difference between a bronchial. A bronchial is your airways here, right? Like here. Here's your bronchioles because you've got your two bronchi and then they branch off into bronchioles. Okay? So it's a lot going on in the body. Okay? So these are fundamental facts and pieces of information you have to know and understand in order to understand these important topics here. For example, laryngoscopy. So if you see this on the NCLEX, so laryngoscopy is so important. We don't often get to see this unless you know do ICU or you work in the OR. And so you can do laryngoscopy through the nose or through the mouth, okay? And laryngoscopy is basically using a camera to look at the larynx. And remember, your larynx is your voice box. And I always, looking at the larynx from the side, it's ridiculous because you're like, what am I looking at, right? But when you look at it from the top, you see the V for your vocal cords. So that's what I was talking about. And oh my gosh, this picture is a good representation to show you. The trachea is in the front, the esophagus is in the back. So I always think I have to breathe first before I can eat. So my trachea is in the front of my neck and then the esophagus is behind it. So when we're intubating a patient, you can intubate through the nose or the mouth, but most often it's through the mouth. And so when they go down here, it's really hard once they get to this junction, once they get to this point. And in the picture, it looks so easy, right? But on a real human being, it is so difficult. You're like, oh my gosh, do I go this way? Do I go this way? Especially if the patient is very heavy, especially if it's an emergency situation, you don't have a lot of time, the patient is dead, we're doing CPR, it's a lot of pressure, right? So one of the landmarks they look for is they look for the vocal cords. And if they see that, they are more confident that they are going to properly place the intubation tube in the right area, which is we want to intubate the trachea. Okay, so anyways, laryngoscopy, you're using a camera to look at the larynx. Okay, bronchoscopy, you're using, oh, and then this is called a laryngoscope. Okay, and remember, you can go through the nose, you can go through the mouth. Then we have a bronchoscopy. We're using a bronchoscope, which is a camera, and we're using it to look at the bronchioles. Okay, so as we can see here, we have the healthcare provider using the bronchoscope. And so as we can see, they're checking for abnormalities. I witnessed a bronchoscopy for a patient who was in severe respiratory distress and suctioning wasn't really helping the patient. So they did a bronchoscopy just to help suction the patient because her airways were very junky. So what do you think we heard? Do you think we heard more crackles or do you think we heard more rhonchi for this patient? More Ronkai. Very good, very good. And so this picture shows you that This is the management of a central airway tumor using rigid bronchoscopy. So they used a bronchoscope and they first visualized that the patient has a tumor obstructing the left bronchi. Okay, so maybe this patient had signs of respiratory distress, right? Because this is outright airway obstruction, right? This isn't even like obstruction because of like swelling or an asthma attack or anything. This is outright airway obstruction. And so this patient probably had multiple respiratory symptoms or manifestations. And then so they probably did like a chest x-ray and saw like blockage in the bronchioles. They maybe did a CT and first visualized this, and then now they're following up with a bronchoscopy to more properly identify this. They can get a tissue biopsy of this so that they can evaluate this tissue under a microscope, and that's how they will classify it of what type of tumor is it, right? And then it will say like, is it stage 1, 2, 3, 4 cancer? So here we have the tumor, and then so this is after the bronchoscopy. They debrided the tumor and ablated it. So during the bronchoscopy, so this bronchoscopy was diagnostic. They diagnosed that there is a blockage with the tumor, and then it was interventional because they actually removed the tumor and burned part of it off, right? And then here we see and see, unfortunately, the tumor started to come back, okay? And it was actually compressing the trachea, okay? Because as we can see, um, at least in B, you can see two holes, right? But in C, you only see one. So there was some compression going on here. And then D, what they did is they relieved the obstruction by placing a silicone stent in the shape of a Y so that the obstruction was relieved. So as we can see, this procedure was definitely life-saving for this patient. Okay, so now you've learned laryngoscopy to view the vocal cords. That's very helpful and necessary for intubation. Bronchoscopy is to view the bronchioles. Then we've got thoracentesis. So write this down. Anytime you see the word centesis on NCLEX, it means to aspirate fluid. Anytime you see the word centesis on the NCLEX, it means to aspirate fluid. Okay? Because you have pericardiocentesis, you have thoracentesis, you have paracentesis, you have amniocentesis. So anytime you see the word centesis, they're taking a needle and they're pulling fluid out of a space. So thora means thorax. This is the thorax, okay? So as you can see, this patient has what we call a pleural effusion. Okay, so let's break this down a little bit. Let me get my tools. And most of the time when they perform a synthesis, and they don't say, oh, I'm going to perform a synthesis. No, they're going to say when they perform a thoracentesis, but whenever they're performing an aspiration of fluid from a space, most of the time that fluid was not supposed to be there, but not all the time. Like when they do lumbar puncture, maybe they're just testing the cerebrospinal fluid, right? But in this case, does it look like that fluid is supposed to be there? Does it look like this fluid is supposed to be there? No, right? It looks completely inappropriate because look at the size of the right lung. This is the size of the right lung. And then look how collapsed the left lung is. The left lung is severely collapsed because the fluid is pushing up on it. And so that left lung cannot properly expand. And so the patient is going to have a lot of respiratory distress. And that respiratory distress, do you think it's going to get better when they lay flat or worse? It's going to be very, very hard for them to breathe if they're laying flat. And so the position she's sitting in, it's an ideal position for the procedure, but also it's the most ideal position for her to be in until this pleural effusion is resolved. So, what is the name of this position? This is called the tripod position. So, this is a very good position for patients. Let me change the color of the font. Okay, so it's when you're sitting upright and you can either, the patient can either put their elbows on their knees, but more likely it's on the bedside table. And it's very good for COPD patients and patients with pleural effusion. Okay, and then even the epiglottitis patients, but the epiglottitis patients, they do this on their own. They don't even, because they'll naturally want to sit up. They won't want to lay down because they'll get so short of breath. But okay, so then we're going to learn about pleural effusion. So this, what you're seeing in this whole lung is a pleural effusion. So I want you to know effusion. Okay, effusion means to fluid where it's not supposed to be. Okay, so remember last week we learned about a pericardial effusion. What was that called? What's a pericardial effusion called? Or what does it cause? Didn't we learn about cardiac tamponade? Right? Pericardial effusion is when there's too much fluid around the heart, right? And then you get Beck's triad. Remember we learned about that? So anyways, an effusion is when there's too much, when there's fluid in a spot where it's not supposed to be, okay? Okay, for my students who speak Creole, all right, don't think this is disrespectful, but I think when I think of infusion, I think the two F's, I think fluid fue quand, like, or fluid qui au côté le pas supposé y, right? So you could think infusion, oh, they found fluid somewhere where there's not supposed to be, or you could think fluid fue quand, like, where did that fluid come from, being in a spot where it's not supposed to be? So, how we're going to fix an issue with too much fluid, we're going to aspirate it out. And that's what thoracentesis is. Okay, so some important takeaways for thoracentesis. The number one, and this is in your study guide, make sure you know this for NCLEX. Make sure you know this for NCLEX. Make sure you know this for NCLEX. Okay, let me share the screen with you so you can see where I am. After a thoracentesis, the number one priority is breathing because the lung can accidentally get punctured during the procedure. Okay, so one of the things that we're going to carefully monitor the patient for is their respiratory rate, their oxygen saturation, listen to their lung sounds. Okay, Do you expect the quality of their lung sounds? So let's say a patient needs a thoracentesis. They obviously have a pleural effusion if they need a thoracentesis. That makes sense, right? Does that make sense? That exactly. Okay, beautiful. So just keeping in mind, if your patient is getting a thoracentesis, they have a pleural effusion, like 99% of the time. Okay, so how would you expect the quality of the lung sounds to be on the affected lung before? It would be poor lung sounds before, right? And then afterwards, would you expect that the quality of the lung sounds have improved after the thoracentesis? Exactly. That's what I want you to know for NCLEX, okay? So for thoracentesis, I want you to know your number one priority is breathing because the lungs can accidentally get punctured. So if you get a question talking about the patient had a thoracentesis and now their respiratory rate is 30, we're going to sit them up and put them on oxygen and contact the healthcare provider. Maybe they're going to order like a emergency CT scan to see if there has been any soft tissue damage to the lungs, okay? Or maybe things could get bad really quickly and they need to be intubated, all right? And then I want you to know after bronchoscopy and laryngoscopy, your number one priority is airway because the airway was accessed during the procedure, okay? Some other terms I want you to know is lobectomy. Lobectomy is the removal of a lobe of a lung. Your lungs have lobes, okay? Your right lung has three lobes. Your left lung has two. So if they just remove a lobe of a lung, that's called a lung lobectomy. If they remove an entire lung, that is called a pneumonectomy. So make sure you know those. And for obviously for those, airway and breathing would be the priorities. For homework, make sure you read the nursing priorities after lung procedures. Okay? Now, we're going to take a short break, and when we come back, we're going to learn about the different oxygen delivery devices. We're going to learn what is the difference between a nasal cannula, a face mask, venturi mask, and this is the golden ticket here. What is the difference between a partial rebreather and a non-rebreather? That is going to take you far on NCLEX. We're going to learn the difference between CPAP and BiPAP. We're going to learn the difference between tracheostomy and intubation. All right, we have a lot of fun ahead of us. You wanted to be a nurse, it's too late now. You're going to make it. All right, so this is a lot of heavy, material. Let's take a 10-minute break, go drink some water, come back refreshed. I'll see you in 10 minutes. Thank you. Okay, so now we're going to move on to the oxygen delivery devices. So make sure you are reading your study guides because all of this information is in there. So first off is FiO2. It stands for fraction of inspired oxygen, but people just say FiO2. And it means how much oxygen are you giving the patient? How much oxygen is the patient receiving with what they're using to breathe? Okay, so here are the different oxygen delivery devices. So you can have a normal way of breathing, which all of us are. If you're able to take a deep breath in and out on your own with no machine, with no device, with no help, you are, thank God, right? You are on room air. Okay, now if the patient needs help, getting a higher level of oxygen in their body, we will supplement that. And that's why these are called supplementary oxygen delivery devices: nasal cannula, face mask, venturi mask, partial rebreather, non rebreather, CPAP, BiPAP, mechanical ventilation. So, room air. Everybody take a deep breath in and out. You just breathed in 21% of oxygen. That is hilarious, right? The air that we're breathing is only 21% oxygen. I forgot what the rest is. I don't know if it's like nitrogen or something. I don't know. But isn't that crazy? 21% of what you breathe in is oxygen. So, if while the patient is on room air, if their oxygen saturation is too low, we have to supplement it. And usually we do with a nasal cannula. Now, if we jump to a nasal cannula, this can go up to an FiO2 of 44%. So we can pretty much double how much oxygen they receive by using a nasal cannula. How much oxygen they receive through a nasal cannula, we describe it in liters per minute, and it goes up to 6 liters per minute. Nasal cannula is usually for short-term use. However, if we're going to use nasal cannula more long-term, we need to use a humidifier because the air that comes through the nasal cannula, it can dry the nose, the nasal mucosa, and it can cause it to crack and be very painful and uncomfortable to the patient. Have you ever been in very, very cold weather, or have you ever been very, very sick and when you breathe in it hurts and it feels better when you breathe like under the sheets? We don't want our patients to feel like that constantly, right? So remember, for long-term oxygen use, they need a humidifier, and I'll show you what that looks like. And we're going to do skin checks. COPD patients, we don't use nasal cannula higher than 2 liters per minute because we want to avoid suppressing their drive to breathe. So patients with COPD, when their O2 levels get low, that's what drives them to breathe. So if we give them too much oxygen, they're not going to be stimulated. Their diaphragm won't be stimulated to move and breathe. Okay? So here's the nasal cannula. So look at the picture and you can see this is a humidifier, or this is connected to humidification. So this is the humidifier water. And so what's going to happen is air is going to blow into here and the water is going to, bubble. And then the humidified oxygen is going to be sent to the patient. And so they're breathing in humidified oxygen. Regardless, remember to always turn this dial. It's usually to the right. Okay, you turn it and you're going to see this ball float up. So if you don't see the ball floating up, the oxygen is not on. Please, for the sake of your patients' lives, always make sure the oxygen is on. Also, when we're talking about medical gases, green is usually oxygen and then yellow is just air. So we don't want to use the air because we just learned that air is only 21% oxygen. So this green one is 100% oxygen is available, right? But we just titrate to how much, because not everybody needs 100% O2, right? Some people, let's say their O2 saturation is just 92%. We don't have to like full force BiPAP, right? No, their O2 saturation is just slightly low. Let's start it off small with a nasal cannula at 2 liters per minute and let's see what happens. Okay, how many liters per minute is this patient receiving based off of this picture? Look at the numbers. Where's the ball floating? Where's the end of the ball floating to? A 5. Very good. So if you were giving a report, you would say the patient is on O2 via nasal cannula at 5 liters per minute. Okay. Um, what's the highest we can go up to with a nasal cannula? 6. Very good. So sometimes you're going to see in the nursing home or wherever, oh yeah, we've got the nasal cannula up to 10. Why? It's not effective after 6. Okay. If the patient is not stable on 6 liters nasal cannula, if they're still not stable and they're at 6, then we need to use another oxygen delivery device. Okay. Maybe then they need like a non-rebreather. Okay. But usually they do nasal cannula, then face mask, and then uh, non-rebreather. Okay, and then from non-rebreather they can do BiPAP, and then if BiPAP doesn't work, then they do intubation. Okay, so this is why we do skin checks on all patients. If your patient has been on if they've just been on a nasal cannula for 3 hours because they had surgery and they're recovering, that's one thing. You would still take a look, make it part of your assessment. But remember, that plastic pressing down on the tissues, the nasal mucosa is very sensitive, okay? In areas where there's supposed to be moisture, it's very easy for them to break down. So we have to check this poor baby. You know, he doesn't deserve that. Bless his heart, okay? This is also anywhere the nasal cannula touches the skin, you have to do skin checks. Okay, so remember, if your patient is on nasal cannula long term or regardless, you are going to do skin checks and you're going to make sure that the oxygen is humidified. Respiratory therapy can help you set this up, but if not, you just get a Christmas tree, you connect the humidifier bottle, then you connect the oxygen tubing. And this is the same tubing that's going to turn into the nasal cannula that you put on the patient. Okay? If you feel unsure, ask your charge nurse or whoever is precepting you when you first start on the floor. Okay? But if there is a respiratory therapist, ask the respiratory therapist. And while they're doing it, watch them and ask if they can show you so that you feel comfortable doing it. Okay? Every facility is different. Some facility you don't need an order to put it on humidifier. Some you do. Just ask your charge nurse and say, "Do I need an order to put the my patient on humidified oxygen?" If they already have the order for the oxygen, and just ask. Everywhere is different and you won't know until you assess. Okay, these are some foam protectors you can use. So if your patient is on oxygen long term, I've seen the gray ones before, okay? And you can put them in the hot spots like behind the ear, under the chin, okay? Next up is a face mask. A face mask can go up to a FiO2 of 60, so you can triple the amount of oxygen that your patient is receiving. Okay. Um, so remember, the oxygen coming from the wall in the hospital, it can go up to 100, right? But it depends on the delivery device that you're using. So if you're using a nasal cannula, it can only go up to 44% oxygen, which is achieved at 6 liters per minute, right? So if we're using a face mask can go up to 60, okay? And we still talk about it in liters per minute, okay? It is more uncomfortable and restrictive than a nasal cannula because you can't eat or drink on this, okay? It must be removed for them to eat or drink. You have to make sure that it fits over their nose and mouth, and it is used when hypoxia does not resolve after using a nasal cannula. So usually the patient starts off on room air, they're short of breath, hypoxic, we put them on a nasal cannula. If going up to 6 liters per minute does not resolve the hypoxia or their shortness of breath, we can try a face mask because we can triple the amount of oxygen they receive. Then we have a Venturi mask. So let's look, tell me the difference. So look at a face mask, right? Look at the face mask. Look at all of the structures of it. And then look at the Venturi. What's different? Venturi mask, face mask. Venturi mask, face mask. What's the difference? The Venturi mask has this green thing, right? Eggs, yes. Very good. And remember, everyone, put your real name. Somebody is just called Zoom user. Put your real name. And somebody put MJ. I love that because I love Michael Jackson and I love Michael Jordan. But put your real name, okay? So that I know who it is, so I can know who needs more help or who I don't hear from a lot so I can check on them, okay? So yes, a Venturi mask, it has what we call an adjustable aperture, okay? And they have different colors. So what the Venturi mask is most popular for is it has these adjustable apertures that will deliver accurate amounts of FiO2. So depending on the aperture that you choose, okay, so let me show you a picture. It it will give you the most accurate FiO2. So these are the different color apertures, and each one, I believe, I want to say the orange one is the 100%, but I really don't remember. But you don't have to know like, oh, what each color stands for, honestly. In nursing, if the patient is on a Venturi mask, respiratory therapy is the one who put them on it, right? The doctor just orders the oxygen, right? But it's respiratory therapy that's going to come in and play with, what oxygen delivery device is working best for the patient. It's up until like, oh, the patient needs like BiPAP and intubation. That's when, things get really, collaborative where the healthcare provider definitely is involved. But respiratory therapy is the one who's going to be playing with this and they'll choose the correct aperture. But like just say for example, like this one is 20, 30, 40, 50, 60, 100, right? They all deliver an exact amount of FiO2. Okay? And that's all you have to know for NCLEX. It will deliver the exact amount of oxygen you want depending on the aperture that's chosen. Next up is a partial rebreather mask. So partial rebreather. So let's talk about it and then let's break the name down so we really have to know the difference between a partial rebreather and non-rebreather. That's the goal here, for you to go into NCLEX knowing the difference between a partial rebreather and a non-rebreather. So partial rebreather, it keeps the first 150 mLs of air that you breathe out into a bag because that air is still high in oxygen, and the patient is going to rebreathe a small portion of that exhaled air. So that's why it's called a partial rebreather. The patient is going to rebreathe a partial amount of air. Okay, so what is important as a nurse is we always have to keep the bag 2/3 full. So we don't want to, and I know it looks flat in this picture, which is not good, but we never want this bag to be flat. So think of this bag as a representation of the patient's lungs. Just like you don't want the patient's lungs to be smushed flat, you want their lungs to be nice and open and filled with air. We want that bag to be nice and open and 2/3 full with air. Okay? And this is good for respiratory alkalosis. Respiratory alkalosis, when they are breathing too much, right? And they're losing their CO2. When they breathe out, it's kind of like breathing into a paper bag, right? So they're going to breathe in, and the bag is going to hold some of that air, and then they're going to rebreathe that air back. Okay. Then we have a non-rebreather, which does exactly what it says. You're not going to rebreathe any exhaled air. So this FiO2 is 95 to 100. So this patient is in severe distress, okay? If your patient has an O2 saturation of 93% on a non-rebreather mask, why? Why? Right? This is for patients, O2 saturation 79, and their, vital signs are very unstable. This is for a very, very unstable patient who, if this doesn't work in stabilizing them, or if this doesn't help to stabilize them, then we're going to move on towards BiPAP and intubation. Okay? So think of non-rebreather as almost the last stop of non-invasive breathing devices, because you have non-invasive breathing devices and then you have invasive, which would be the intubation. Okay, so what's important here is that a non-rebreather mask has a one-way valve, and that one-way valve makes sure that when the patient exhales, that they do not rebreathe any of it back. Okay, it also has two exhalation ports. They look like holes, and that's the NCLEX favorite. Okay, those two exhalation ports have flaps that open when the patient exhales so that the air gets out, and it closes when the patient inhales. So when the patient exhales, the flaps open so that the air gets out, and when the patient inhales, the flaps close so that this reservoir bag, which has the oxygen, they can breathe the oxygenated air in. Okay, so this is the one-way valve. The one-way valve will make sure that this is the way oxygen will get inside the patient. The oxygen from the wall, we connect the non-rebreather mask to it, and we can see the oxygen will come through the tubing and enter the bag. The patient will breathe the oxygen in, and when the patient breathes the oxygen in, the exhalation port will be closed. The two flaps are closed so the patient can breathe in. Now, when the patient exhales, the exhaled air will not go in the bag because there's a one-way valve. And when the patient exhales, these flaps will open so that the air will exit. Okay? Does that make sense to everyone? Okay. All right. And another very important NCLEX topic is keep the bag fully inflated. Okay, so with partial non-rebreather, you keep it partially inflated, but with non-rebreather, you keep it fully inflated. So just think of this bag like your patient's lungs. You don't want your patient's lungs all smushed and looking like dead on the side of the road. No, you want your patient's lungs to be open and filled with air. You want that bag to be open. Make sure that oxygen is connected. Make sure there are no kinks or twists in the tubing. If something is pressing against the tubing and if oxygen does not get in the bag, the patient will suffocate. Because think about it. If there's no oxygen in this bag, when the patient inhales, these ports, the flaps are closed when the patient inhales, right? And if there's no oxygen in this bag, they're not breathing anything. Okay? So please, please, please make sure you have a good understanding of non-rebreather mask. The FiO2 is 95 to 100%. So we crank up, turn that oxygen dial up all the way. That black ball should be floating all the way at the top. You should put it all the way to the top, the oxygen. Crank it up. Remember, how does oxygen get inside the patient with a non-rebreather mask? You connect it to the oxygen on the wall. You turn it right all the way up until that little black ball is floating all the way to the top. Okay? And you'll hear like a hissing too. And you'll know the oxygen is working because the bag will inflate. Okay? When the patient inhales, oxygen is going to go here and enter their mouth. When they inhale, the two flaps on the exhalation ports are going to close inwards, right? So they breathe in. And then when they exhale, the exhalation flaps will open so that the exhaled air gets out. The exhaled air will not go in the bag because there's a one-way valve, okay? Keep in mind, the only oxygen this patient can get is in the bag, okay? Make sure the oxygen is on, that it's connected, and that there's no kinks or twists in the tubing. Also, please, 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 make sure. And you know what? I'm going to turn this into a question. Can you put this on an unconscious patient that you're doing CPR on? There it is. Oh my gosh, I'm so proud. Very, very good. If you understand that this early on, you've got what it takes. I'm telling you right now, you've got what it takes. Very, very good. Every oxygen delivery device we've talked about so far, room air, right? Nasal cannula, face mask, Venturi mask, partial rebreather, non-rebreather, you have to be conscious. You have to be conscious to draw the air in. Very good. That's a very high level of thinking. Now, when we get to non-invasive positive pressure airway devices like CPAP and BiPAP, okay, that's going to force air in. That's one thing, right? And then when we've got intubation and tracheostomy, it doesn't matter. The air is going in, right? Very good. So make sure for all of these delivery devices we've learned so far, the patient has to be able to breathe on their own. So if they're passed out dead and we're like, oh my gosh, and we're doing all the steps of a code blue and we're like, okay, the patient's not breathing, they don't have a pulse, don't put this on the patient, okay? We're going to do the ambu bag and then if necessary, intubation, okay? And let me show you an ambu bag. This is an ambu bag, okay? Now, you connect it, you see this tubing, you connect this tubing to the wall and you make sure the oxygen, I always turn the oxygen on first because I want to hear the hissing. And in this, you would turn the oxygen all the way up. The little black ball should be floating all the way to the top. And you connect it and you know, when you're doing CPR, 30 compressions and then you give them 2 breaths, okay? You can use this without oxygen, okay? Then you would just take the tube, this part you would just remove it and it will draw air from the atmosphere into the bag. And then when you give the 2 puffs into the patient, but remember the atmospheric air around us is 21% versus the air that can come from the wall is 100%. So which one do we want to use in an emergency? The one from the wall. Very good. And then there's another good picture I want to see. I want to show you. So this picture here, okay, this is what we call a bag valve mask. The only thing I don't like about this picture is she should turn the back. You can twist the bag. So she should be standing at the patient's side. Let me find a better picture. Hold on. I want to show you a better representation. But it's called BVM bag valve mask. Okay, so this is more appropriate, and she has what we call a CE grasp, and there's like a triangle part. There's a triangle part to the, let me show you, hold on. So bag valve mask, okay? So this is the valve, okay? And this is the mask. And you see there's a triangle part and there's like a U part. So you want the triangle part over the nose and you want the U part like up against the chin as much as possible. And you want to use a very firm grasp. And you're going to do a C from the nose towards the chin and then the E holding underneath the jaw to lift and make sure that the airway is open, able to receive the oxygen. Okay, and this is the bag part, the bag valve mask, BVM device. So this is another oxygen delivery device, and if it's connected to 100% oxygen, we can give the patient oxygen when they are unconscious, and we will continue using this. And so it'd be 30 compressions and 2 breaths, and 30 compressions and 2 breaths until the doctor decides that we need to intubate the patient. Okay, so what's the difference between partial rebreather and non-rebreather mask? A partial rebreather, you breathe a partial amount of air you just breathed out. Non-rebreather, you're not going to rebreathe any old air. That old air is going to get out of the mask. And also, partial rebreather mask, you want the bag partially full. Non-rebreather, you want it completely full. Remember that reservoir bag is a representation of your patient's lungs. You do not want it flat. All right, everyone okay so far? Okay, I want you to be strong in this. You already are very intelligent. I want you to be strong in this for your NCLEX so that any question they give you on the oxygen delivery devices, you are good. Okay. Next up is CPAP versus BiPAP. Okay, so CPAP and BiPAP are what we call non-invasive positive airway pressure. Okay, so write this down. Positive is to force inside, to force in. Write this down. Positive is to force in, negative is to suck out. Positive airway, positive pressure, you're forcing something inside. Negative, you're sucking out. So I have a question for you. If you're suctioning a patient, is that positive pressure or negative pressure? If you're suctioning a patient, so you're suctioning, they're negative, very good, because it's like a vacuum, you're sucking out. Think of negative pressure like a vacuum, you're sucking something up. Right. So when we're talking about CPAP and BiPAP, it's the negative of suctioning. We're not sucking something out, we're forcing air in and very aggressively, okay? CPAP and BiPAP are very aggressive, forcing air in because the patient has a problem where maybe their airway is not opening. And so that the pressure that that device will provide will keep the air, it will force the airway open with how much pressure it provides. CPAP and BiPAP just do it slightly different. CPAP is continuous. Continuous positive airway pressure. That's what CPAP stands for. Continuous positive airway pressure. It uses the same amount of pressure to force the airway open and force air into the airways. It is useful for obstructive sleep apnea. The issue is it's very uncomfortable because again, it's forcing air in, and it is, have you ever walked by a fan that it just like it kind of startled you, like the fan was just goes in your face and you're like, oh my gosh, and your heart kind of skips a beat a little bit? Has that ever happened to you? Like, let's say somebody put a blow dryer in your face and it's like the blow dryer's on high and you're like, you feel a little palpitation because it's like shocking, like, oh, I wasn't expecting that. Tell me in the chat, has that ever happened to you? Imagine that for the whole 8 hours of night, like in your mouth, this device just like forcing air. It's very uncomfortable, okay? And also because air is constantly being shoved in, it's really hard for the patient to breathe out, okay? Because they have to fight against the CPAP to try to breathe out. Here with BiPAP, BiPAP stands for, hold on one second, everyone.
Cafeteria Anderson.
Love you. Okay, I'm gonna do my in class.
Eh?
I'm gonna do
Mbral voye $20 for $30 for voye pou mwen na cash app. Tan pri please, okay? Telefon mwen koupe. Okay, bye. Thank you, bye. Eh? 130 something. Spectrum, yeah. Okay, thank you. Map voye bay la pou konya, bye. Pou mkay manjou bagay. Please, yeah, I'm gonna go, bye. Bye. Love you, bye.
everyone. Please give me just one moment. Thank you so much. I apologize. I was speaking while I was still muted. So we're going to watch a couple of videos, and each way along the way, we'll talk about it to make sure you understand the key pieces of information to know and understand, to pass the NCLEX, and to be a safe nurse.
In this video, we're going to look at trach care. Remember, you should always suction the patient before trach care. So if you haven't watched that skill video yet, make sure that you watch it. Remember, as you're doing this, you want to be assessing the stoma for signs of infection or skin breakdown while you look at it. The other thing to remember is that if the patient coughs, you could be exposed. So we always recommend goggles or a face shield during trach care. So the first thing you want to do is open your sterile trach care kit, and if it doesn't come with a good amount of gauze, you can also open an extra sterile 4x4 pack of gauze. Then you want to pour a sterile saline solution into a compartment within your tray or into the pack of gauze. So there's other supplies you might need access to, so you're going to open those onto your sterile field inside your kit. The new dressing, the new inner cannula, and the trach ties. So now if your trach ties or trach holder isn't sterile, just open it and set it next to the sterile field. So apply a pair of clean gloves. And the first thing that you want to do for trach care is remove the inner cannula. Now, most of the time these are disposable, so this one will just get tossed. If you don't have disposable, you will have to clean it. You also want to remove the old dressing and then remove your gloves and perform hand hygiene. Now you can grab the sterile glove pack from the kit and put on your sterile gloves. Again, go to the sterile gloves video here if you need help or need some review on how to put on sterile gloves. Throughout this entire procedure, you want to keep your dominant hand sterile. So now that you're sterile, you can finish setting up everything inside of your kit. A lot of times there will be a sterile drape that you can use to lay over the patient's chest. Just make sure you keep your hands sterile. If you don't have a drape, you can also lay a towel over their chest before you get started as well. So the first thing we need to do is clean the secretions from the flange of the tracheostomy. So you'll use a combination of cotton tipped applicators and pipe cleaners, just depends on what you have in your kit. So just remember, you never insert these into the stoma itself. If needed, you can dip them in the saline solution and you're just going to scrub around the flange. So depending on the patient, how long that they have had the tracheostomy, how long it's been since trach care, you might need to use 3 or 4 of these cotton tipped applicators or pipe cleaners to make sure you get all of the secretions off. Remember, all those secretions are out of the lungs. If we leave them there in that area, we're just increasing the risk for infection and skin breakdown. So the next thing we want to do is clean under the flange and around the stoma itself. And to do that, we're going to use our saline soaked gauze. So pick up a piece of gauze and wring it out so that it's not dripping. And then you're actually going to feed it up underneath the flange. And if you need to, you can actually grab a clean, sterile cotton tipped applicator if you still have one and use that to kind of push it through. And then you're going to bring that piece of gauze up through underneath the flange and just keep repeating that on both sides of the tracheostomy tube itself to make sure that you get all of that nice and clean up underneath the flange. You can also use a dry piece of gauze in the same manner. Just tuck it up underneath and pull it out from the other side to help dry the area and dry around the stoma. Now, once you're satisfied with the cleaning, it's time to replace the inner cannula. You want to put it in at an angle first and then follow the curvature of the cannula in order to put it into the trach, and then make sure that you lock it in place. Now, if you don't have a disposable and you need to clean your inner cannula, use the brush in the kit and the saline solution. Notice we don't use hydrogen peroxide unless there's an obvious skin infection. It prevents healing. So now it's time to change the trach ties. Make sure your new ties are ready to go and within arm's reach. You will always want to keep one hand on the trach itself and start by untying one side of the existing ties. Now, if you have a Velcro tie holder like this, simply undo the Velcro and pull it out. Then you're going to insert the new ties through that one flange hole and secure it. Remember, you always keep one hand on the trach in case the patient coughs. That thing could fly right out. So once you insert the new ties on one side, you're going to slide both the new and the old ties behind the patient's head, still holding the trach with one hand. So now you've pulled the old ones out and the new ones across. And now you can remove the old ties from the other flange and secure the new ties to that side. The big thing here is just make sure that your ties are not twisted. Any twists in those ties can cause pressure ulcers in the back of the neck or the side of the neck. So once you've pulled the ties through, you can secure them with a knot. If you don't feel comfortable doing this yourself and having one hand on the trach, get a helper. Have somebody come in and just put their 2 fingers on the trach for you and hold it while you do this. Once you tie these, make sure that you can still fit 2 fingers snugly underneath the ties. Too loose, the trach can come out. Too tight, and it can irritate the patient, make them cough, and cause pressure problems. Now, the last step is you're going to carefully place the new split dressing under the flange and around the trach. Again, if you need to, you can use a tip of a cotton tipped applicator just to help push it up under the flange. Either way, make sure that it's high enough to be under the flange and prevent skin breakdown. Then you will label your dressing per facility policy, discard all your supplies, and document your procedure. Easy as that, right? So the big thing to remember here is the respiratory system is sterile. So anything going into the trach or around the stoma has to be sterile. And of course, remember to keep one hand on the trach at all times when you're changing the ties. That thing will fly across the room. All right, guys, I hope that was helpful. Go out and be your best selves today. And as always, happy nursing.
For watching another nursing.com lesson. Click the link below in the description to watch.
All right, everyone. So that is a very, very good video. And Nursing.com is a wonderful website. They have a lot of free resources that you can also use. However, I want you to stay focused. I don't want you to overwhelm yourself. You're going here, you're going there, you're going here, you're going there. Making sure you're reading the study guide, making sure you're coming to class, making sure that you are taking notes and that you're reviewing the recordings and then adding on to your notes and then doing questions to practice. That is what will help to prepare you. But nursing.com does have a lot of extra cheat sheets and very helpful things that will help you. So let me put on another video and then very shortly we're going to discuss more information.
Our game changer for sleep that stays is here. Garnier presents Fertility Sleep and Stay Serum. Shake it, heat it.
But since that... Hi, I'm Ellis with Level Up RN. In this video, I'll be demonstrating how to perform tracheal suctioning, how to do tracheal site care, and how to work with a non-disposable inner cannula. I'll be following along on the steps and best practices included in our clinical nursing skills deck. So if you have the deck, grab these cards and you can follow along with me. If you don't have the deck, then pop on over to leveluprn.com to check it out. After the demonstration, I'll be coming back here to give you just a couple more tips. Tracheostomy care is going to look different depending on the type of equipment that your patient has. So I'm going to demonstrate the steps that are a little bit more complicated. So we'll be working with a trach that has a reusable inner cannula. So I'm going to take the inner cannula out and clean it and put it back in. But you may come across patients that have a non-reusable inner cannula in which you would simply take the inner cannula out, throw it away, and get a new one. So you would get to skip those first couple of steps. But since that part is a little bit more complicated, we wanted to make sure that you see it the more complicated way. So to start off, I'm going to pull his oxygen down. Now I would usually just kind of pull this down so that he was still getting oxygen during this procedure, but we're going to need to use our imagination a little bit because I want to make sure that you guys have a good visual. So I'm going to set his oxygen to the side there, but just know you can really kind of just pull it down and out of your way while you're working with the trachs. So I'm going to pull his oxygen down a bit. I'm going to open my tray. I have clean hands and clean gloves on. I'm now going to open my sterile saline. With my palm against the label, I'm going to pour some sterile saline into the container and then place this to the side. I can now remove his inner cannula. So I'm going to start by just pinching the flanges on the side here. So I just pinch it and pull, and that's all I'm going to touch on this particular piece. And I'm just going to drop him in his little saline bath. And then I'm going to go ahead and take these gloves off and discard them and put some sterile gloves on. Your kits usually come with sterile gloves, but if you've seen my other videos, you know I just prefer to get my size. And as always, I grab my dominant hand's cuff, slipping that one on first. Then I tuck my fingers in, keeping my thumb out of my non-dominant hand, and slide that one on. All right, so now I can go ahead and clean his trach area. So I'm going to set my little sterile field up. In these trach kits, you have cotton swabs, a brush, and pipe cleaners, actually. You'll also have a new trach tie, so this is to tie on the trach. You'll have trach dressing, and you always only use the trach dressing. You never ever cut a 4x4 to put around a trach. And then just some additional sterile 4x4s. So to start, I'm going to remove his old 4x4, noting that my left hand is now not sterile anymore. I'm going to just dispose of that. I can get some more saline into my container. Again, only using that left hand so I'm not getting my right hand dirty. I'm going to now get some cotton swabs and dip it into the container. And I'm going to clean starting at the stoma itself and pulling out. Just like when we do something like wound care, if I were to start farther away and drag in, I'm potentially dragging bacteria into the stoma and potentially into the respiratory tract, which we know is a sterile tract. And I don't want to do that. So I'm going to start at the stoma site itself and drag outward. And I would get a new swab each time. So I could do this as many times as needed. I could also get a swab and clean the faceplate if there were something like sputum or dry mucosa on that faceplate, which there was a little bit of dry mucosa on there, so I cleaned that off. I can then use this dry sterile gauze to clean the site and discard that as well. I'm now going to pick the inner cannula up with my left hand because I don't need to be sterile to hold these flanges, right? So I've got the flanges. I'm going to use this brush to really scrub in there. This has often got some mucosa in it. So I just insert this just like I was cleaning a straw, if you've got one of those reusable straws. Then I can discard of my brush. And the pipe cleaners are to dry the inner cannula. So I would insert my pipe cleaner. It's hard to get into that main part, and I would just twist it around to dry it. And then once I felt like that was dry, I could put it back in until I hear the click, so that I know that it has clicked back into place and isn't at risk of falling out. To replace my ties, oh, let's do this first actually. I'm just gonna snuggle this up under that faceplate. And again, I only ever use these pre-cut gauze sponges, because if I were to use a 4x4 and cut it myself, I could potentially fray the gauze and some of that could get sucked into his respiratory tract. And I would not want that to happen. All right, and then to replace my tie, I actually first need to make sure that I add my new tie on. And most of the ties these days are that Velcro tie that he's already wearing, but this old-fashioned tie is what came in his kit, so I'm going to demonstrate that. But first, I tie his new tie on before I remove his older tie. Again, just to make sure that there is a securement device and he's not at risk for his trach to be expelled. Come on. There we go. And now I can remove the Velcro from the old tie. And discard of that. And then I would, of course, replace his oxygen and make sure he's in a comfortable position. And that's how I change and clean my patient's tracheostomy site.
Excuse me, you're reading wrong. Put these on. Show me your.
In this video, we're going to talk about suctioning a tracheostomy. Now, you may need to do this before you do trach care or just because the patient requires suctioning. Just make sure that you assess the patient before you start so that you know what their lung sounds are and what their oxygen saturation is before and after suctioning. So first thing you want to do is make sure your suction setup is working. You should have tubing attached to a canister attached to a regulator. For this, you want to set it on continuous medium suction. You also want to make sure that you can reach the end of the tubing. Sometimes I just lay it over the head of the bed or on the patient's chest. You can also loosen any oxygen device that they have at this point. So the first thing you want to do is open your sterile water container and just set the bottle on the table between you and the suction kit. Now you can open your suction kit and put on your sterile gloves from in that kit. Now, honestly, sometimes they're all bunched up and sometimes they have their own package. So depending on your kit, just be really careful to make sure that you keep them sterile. Now, in this little kit, what you should have is the sterile gloves, the suction tubing, the suction catheter itself, and a little cardboard water container. So once you get your gloves on, you want to open that little cardboard water container inside that sterile package and set it up on your sterile field. Now, sometimes, especially if I get another package of gloves, I'll actually use my sterile gloves package as my sterile field here. So open your little cardboard water container. And the next thing you want to do is grab the suction catheter in your dominant hand. Put the tip downwards and wrap it backwards around your hand. That way you can grab onto the plastic end of the suction canister. Now with your non-dominant hand, you can grab the sterile water, pour some sterile water into the container. Remember, that hand is no longer sterile. Grab the suction tubing and connect it to the plastic part of the suction catheter, being careful that only your sterile hand touches the catheter. Now at this point, you are ready to suction. So use your non-dominant hand to move any oxygen mask if you have it. And with the same hand, you're going to use to control the suction port with your thumb. So you're going to slowly insert the catheter into the tracheostomy until the patient coughs or you meet resistance. And then you're going to apply intermittent suction while you twist the catheter on its way out. Once you're out, hold that catheter away from the patient to keep it sterile. Replace their oxygen source with your non-dominant hand if you need to, and decide whether or not you think they need another pass. Now, if the secretions were super thick, you can actually suction some of that sterile water through the catheter to clean it out. Now, you can do up to 3 passes with one catheter, but no more than 10 seconds per pass. So again, insert the catheter and remove while applying intermittent suction and twisting the catheter. This just helps that we get all the secretions off of the edge. When you're done, you can wrap it up in your hand. Again, make sure that you see the patient's oxygen saturation is improved. And then you always want to listen to their lungs again to make sure that you've actually made a difference and gotten the secretions out that you wanted. All right, guys.
All right, everyone. I know that was a lot of videos, and you are going to get all of these videos in the document with the recording from today. But let's just talk about some major important topics that you have to know for NCLEX and be comfortable with so that you can be successful with NCLEX when it comes to tracheostomies. So hang on one second. All right, give me just one moment, guys. I'm just trying to load up a study guide I made for you. Okay, so this is a another part of the study guide that will be included for you with the recording today. So please make sure you include it in your studying. So tracheostomy, what do you need to know for NCLEX? Why does a patient need a tracheostomy? So they have some type of airway obstruction like a tumor, swelling, or burns. They need long-term mechanical ventilation or secretion management or airway protection. So immediate post-op priorities. I know the videos didn't talk about this, but these are some important post-op priorities to know for NCLEX. So immediately after a patient has had the surgery to have a tracheostomy created, the first 24 hours are the most critical. We have to maintain an open airway. So that's called airway patency. We want the airway open, so we're going to monitor for obstruction from any mucus, dislodgement, or bleeding. So if we have lots of mucus, we're going to use suctioning. If the tube is dislodged, if the tracheostomy is new, less than 72 hours, do not attempt to reinsert. Action is to call for help, cover the stoma with sterile gauze, and ventilate with a bag valve mask over the mouth or nose if possible. Okay? And then the patient is going to have to do surgery for us to fix this problem. If it is greater than 72 hours, we're going to attempt reinsertion. Always make sure you keep an obturator, a spare trach tube. You need the same size and one size smaller, and an ambu bag at the bedside. Equipment to keep at the bedside: obturator, 2 extra trachs, current size and one size smaller, ambu bag with oxygen, suction setup, sterile gloves, and a trach care kit. All right. Suctioning procedure. Remember, everything about trachs needs to be sterile because the respiratory tract is a sterile tract. We don't want to introduce bacteria and organisms to the respiratory tract that can lead to pneumonia. So, suctioning procedure. The purpose of suctioning a tracheostomy is to clear secretions and to maintain an open airway. So we always pre-oxygenate the patient before we suction for about 30 to 60 seconds with 100% O2. You apply suction intermittently while withdrawing. So you apply suction for less than 10 seconds and then you are moving up the trachea. You don't want to keep it down. You want to move up. You wait 1 to 2 minutes between passes. The limit is 3 passes per session, and you monitor O2 saturation. The signs that suctioning is needed: if you hear gurgling, you see visible secretions, the patient is restless, breathing too fast, or has a decreased O2 saturation. Cuff management. If it's a cuff tubes are used for mechanical ventilation to prevent aspiration. Uncuffed tubes are used when the patient can protect their airway or we're trying to wean them off the trach. You want to maintain a cuff pressure of 20 to 25% to prevent tracheal damage, that tracheal necrosis we were talking about. Tracheostomy care, also sterile. Remember, everything is pretty much maintaining sterile technique. You clean the inner cannula with hydrogen peroxide and sterile saline. Replace inner cannula or change ties one side at a time. Clean the stoma site with sterile saline and pat dry. Change dressing using a sterile gauze. Never cut gauze. You always use pre-cut. Communication support. You provide communication board or writing tools to the patient. Fenestrated tubes or Passy-Muir valves will allow speech when the cuff is deflated. Nutrition and aspiration precautions. The cuff should be inflated during feedings. Suction before and after meals. Elevate head of bed 30 to 45 degrees during and 30 minutes after feeding. Complications and nursing interventions. We talked about the tube dislodgement already, that's above, okay? For homework, you can review airway obstruction, subcutaneous emphysema, infection and bleeding, and we're gonna follow up with those next class a little bit more in depth. NCLEX priority cues. Airway is always first, remember, so if you're have a list of 4 patients, who would you see first? If a patient has a tracheostomy and they're restless, you would go see them first. Check their O2 saturation and suction as needed or assist them as needed. Remember, dislodgement within the first 72 hours is an emergency. You never insert dry or contaminated inner cannula. Do not use hydrogen peroxide for fresh tracheostomy sites. It will delay healing. Suction before trach care to prevent aspiration. Monitor for accidental decannulation and hypoxia. Okay. So a kind of tool you can use for your priorities for trach is called safe air. Suction is needed. Airway patency. Keep that airway open. Fix secure ties, emergency kit nearby, assess for complications, keep the inner cannula clean, and replace the ties one side at a time. Okay, so this will be included for you with the recording. So when I send you the recording today, whenever the recording will finish, you're going to go to so this document is what I share with you every week. It never changes. The study guide is here. The Zoom link is here. The online flashcards are there. You're going to go to week 6 and you're going to see Adult Respiratory Part 1 lecture. So when it's done recording, I'm going to put the link here. You're going to see the 3 videos we just watched. They're all right here. You just click on them. Okay, so for homework, make sure you read chapter 6 in the study guide. The tracheostomy study guide I just reviewed with you is right here, and then review your lecture in your notes. Okay, so when we come back next week, we're going to go back to the tracheostomy study guide to go over the table, so we can talk about complications with tracheostomy and nursing intervention. So it's very, very important that you are caught up with your studying so that you can be able to understand this new information and how we deal with complications. All right, everyone, you guys did absolutely wonderful today, honestly. So thank you so much. So I will see you next week, same time, same place, so we can keep learning and growing and help you get your nursing license. Thank you and have a blessed day.